we need to have a little bit of background, and we review some of the challenges. There are a lot, but we cannot talk about all of them. We will present some of the opportunities, and we'll conclude. Huh?
Can you restart from the beginning?
Restart. Okay, good.
I'm so sorry. Thank you so much.
That's fine. Yeah.
All right, you're ready. You're good now.
Good. Thank you so much for having me in this conference. And I want to share with you a topic that is the surgery in rural Africa, challenges and opportunities. I'm Dr. Ebhele Jacques. I'm a general surgeon working in Malawi, but I'm originally from Democratic Republic of Congo, a French country. So here's what we are going to talk about. We'll give you some of the background, and we'll review some of the challenges, and we present some opportunities that we have in rural Africa, and we'll conclude. Africa is generally known as a continent with so many challenges, including limited infrastructures, shortage in hospital equipment, and lack of economic and human potential. But there is quite a number of mission hospitals that are actually doing well. They are making the difference already. And they are able to influence even the medical system in Africa. But there are still many more lagging behind. In sub-Saharan Africa, you know, the medical missions, they provide 1/3 of medical care. This is a lot. And some of the medical missions are already training centers. They produce high-quality nurses. We produce clinical officers. And recently, mission hospitals in Africa have started already producing even specialists. I myself am a product of, the training within a mission hospital by missionaries, not from a university. This is a very new concept in Africa, but now is doable, through the missionaries. But in order to maintain this growing new element coming up in mission hospital in Africa, we need well-qualified, compassionate, and God-fearing local health professionals. This is only possible through training programs. So we need to focus more on the training of the local healthcare providers. But in order for that to happen, we need faculty. Faculty missionaries from abroad, from overseas, to work together with local faculty in order to train a new generation of healthcare provider in Africa. But all that needs to happen in a very functional healthcare system. You can see here, this is Mbingo Baptist Hospital in Africa. You can see 3 American missionary surgeons, and I'm seated just beside them. We are 2 African faculties, and behind us, you can see 12 general surgeons in training. They are actually our residents. So we are trained by missionaries in mission hospitals, and this is something that really need to be emphasized, because this will bring Africa at a level where we are able to sustain the work of missionaries there. Coming back to my hospital now, I work in Dayang Luke Hospital. This is Malawi. We have a series of challenges, but here we want to review some of them. But before that, you need to understand that Diane Luke Hospital is a 200-bed hospital, pretty small, but it serves 100,000 people around, and we receive so many referrals from some other districts, including the neighboring countries. So the example of Diane Luke Hospital's challenge, I believe that it is more or less the same thing happening in other rural mission hospitals in Africa. So the goal of reviewing those challenges are simply to raise the awareness of those challenges that we live every day. Why? Because some of you may decide to go help in Africa, but it's good to know those challenges already to help you to prepare well so that your mission might be a success. But somebody in the audience may also see those challenges as opportunities to help those hospitals in Africa. But as I say, we have a lot of challenges, but some of the challenges are really basic. It should not be that way, but it is. This is the reality of Africa. Water and electricity are still problems, especially in rural Africa, because missionaries, they want to go in rural Africa to help those underserved population, those neglected population. They want to go there. But here's the first problem they face: water and electricity. It shouldn't be that way, but it is. We have water, but this water runs intermittently. So we have our backup plan. We drill some borehole water, and then we use those borehole water to serve us in the hospital. But unfortunately, in dry season, even those borehole water, they dry up. This is really a challenge. And the electricity is also a problem. Some of you may never see electricity outage, but the electricity is really a problem in rural Africa, in our hospitals. So we rely on generators. Sometimes some of the mission hospitals, they have the solar system that they installed to just try to fill in the gap. Anesthesia. You know, in order to do surgery, you have to have a good anesthesia. But this is really critical. Even the personnel is the problem. We only have one nurse anesthetist. He is not even an anesthesiologist. He's a nurse anesthetist, only one. But we really need 4 or 5. And then on top of that, the anesthesia machine is only one. And even that machine is working partially. It's not completely working well. So this is a problem, because without anesthesia, without anesthetist, the surgeon can do nothing. Another issue is about sterilization. Our capacity to sterilize our material are really limited. As you can see on the picture, we have one main autoclave with a very small capacity, and another one is very tiny for the small instrument and small packs. We can sterilize in that one. So our sterilization capacity is hindering us to do a lot more than what we are already doing. We have equipment and instrument problems. We cannot do surgery without instrument, but this is what we have. Limited linen, limited surgical sets, and sometimes limited essential drugs. But we are able to help people despite that. But the huge problem is the human resource. In the whole hospital, with all full departments, we only have one surgeon, one obstetrician, one pediatrician, and one internal medicine doctor. We don't have urologist. We don't have orthopedist, trauma surgeon, neurosurgeon, plastic surgeon, oromaxillofacial surgeon, all kind of specialties doctors. They are not around. There are even some of the mission hospital where we cannot find even one specialist. They are not around. More of the specialists in Africa, they are concentrated in big towns. They don't want to go in rural area. This is a big deal, a real challenge. For us who work in rural hospital, then you find yourself alone. You really find yourself alone, and then you are on call every day. You have to take care of outpatient in a clinic. You have to do some endoscopies. You have to perform all the elective surgeries. They awake you all the time for the questions. And then on top of that, you have to do rounds to see all the inpatients. And then you add administrative work, like paperwork. It is just overwhelming for one single person. This is a real challenge. And you can recall this is what missionaries were doing some decades back. They come from overseas, they go to the place where they really see the need, and they find that that need is very overwhelming, and they are alone. They would work as a single doctor at that place until they burn out. And when they return, even what they have started will only collapse. This is a huge issue. That is why we need to build a team. We need to build a team to go for mission. And fortunately for me, we have a second surgeon who has just joined the hospital from the beginning of this month. And then when we don't have enough people to work, you have to work even beyond your scope. You know, I'm a general surgeon, but most of the thing I do in that hospital is urology. More than half of my cases is urology. And yet, I'm not a urologist. And the rest of the half is now shared between the general surgery and other subspecialties. In sub-Saharan Africa, it's not surprising to see a general surgeon doing gynecology cases. Most of the time we do hysterectomies, we do C-sections, but we are not gynecologists, we are not obstetricians. But we are doing these because there is no one around to help those needy people. It's not a surprise in Africa, especially in sub-Saharan Africa, where they wake you up at night, you are a gynecologist, but they are calling you to take care of a trauma case. It's not a surprise. So that is why, even though I'm a general surgeon, I'm doing some other cases, just because you cannot even refer the patient. Like, go see a gynecologist. There is no gynecologist around. Go see an obstetrician. There is none around. So this is a challenge in Africa. So if we are saying those things, it's not to discourage, to frighten anybody. It's just to raise the awareness so that you prepare well. When we go to the mission, don't be surprised to be seen or to be called for something that is already out of your scope. I would like you to meet this little boy. His name is Francis Jr. Francis Jr. is the only boy in this family. His father is a pastor. And on the left side, you can see his lovely wife holding Junior. This child has been born with an anomaly. We call that Hirschsprung disease. When you have Hirschsprung disease, you cannot move the bowel very well. And all the time, since birth, this child has been having problems to move the bowel. So his abdomen is all the time distended. And this couple were looking for help since birth. And this child is 1 year today on 2020th. It's 1 year. But they seek for help in our hospital when the child was 8 months with this problem. I told them that there is a pediatric surgeon around. Would you go please to see that person? He said, no, we've already been there. What was done there? And then they explained to me what happened there. But they said there is no hope. Why? Because all the investigation done did not show that this child has Hirschsprung disease. So we did not know what to do really for this child, but God helped us to just have an idea what to do with this patient. After all, they are seeking for help. And we as Christians, we have to give compassionate care. If a patient comes to you, you have to look, what should I do for this patient? In a compassionate way. By reasoning that way, an idea just came into our mind that we need to repeat the biopsy, because that is the diagnostic tool to discover if really it's an Hirschsprung disease or not. So we did the biopsy for this child. It confirmed that this child had Hirschsprung disease. So the father was very happy to carry the result to me, look, it is an Hirschsprung disease. But for me, I knew I'm not a pediatric surgeon. I will refer this couple back to the pediatric surgeon with the new result. But they say, no, we are not going back. We just want you to take care of this patient. Very challenging, right? But, we are praying, we say, God, may you please allow us to find a way out from this issue. And after praying, I just feel like I need to do the operation. Yes, I did it before while I was doing my pediatric surgery rotation. So we know how to do it. So I took this child in operating room. We did the operation very well. You can see how we are pulling that diseased part. And we did the operation. And this child is today 1 year old, healthy, smiling. And the pastor is very, very happy of what God has done for his child. This is some of the challenges we have in rural Africa. You have to work beyond your scope. People come to you begging for help, and you just have to do something because they are hopelessly looking for help. So this is some of the things we do in Africa. So when we tell you this kind of story, it's not to frighten you really, but it's just to make you prepared well for this kind of scenario, because we see all kinds of scenario really. Some of the things we do can never be done here. It will appear illegal, but we do them to help people. Looking at those challenges, and it may seem to some of you like, oh, working in Africa is really a problem. I cannot really work in Africa. Everything seems to not work really. It's impossible to work there. But let me tell you, there is nothing impossible to God. When you are working, you are in front of a difficulty, you seek God. God will guide you and find a way through. So, some of the challenges are very intense, and we have been asking, why? Why, God, you are allowing this kind of thing to happen? Why? You just need to take it away from us. Paul was asking the same question to God, and Jesus tell him, my grace is sufficient to you, for my power is made perfect in weakness. Therefore, I will boast all the more gladly about my weaknesses, so that Christ's power may rest on me. This is Paul's word. So let me tell you, all our challenges, our difficulties, obstacles, hardship, all those are opportunities. They are really opportunities. Look at those quotes. We are all faced with a series of great opportunities, brilliantly disguised as impossible situations. And problems can become opportunities when the right people come together. Those are powerful quotes. And it's true. All our difficulties are opportunities to help other people. May God open your eyes, find an opportunity, and be part of the right team for the mission around the world. May God bless you. Amen. Thank you. Do you have questions?
Which of those challenges are hardest for you?
The hardest challenge for me is the fact that I'm no longer working alone, but working alone was very difficult for me. Because every time you are just there, you have to be in the hospital, and they call you in the middle of night to take care of some of the issues. So all the time you are just on. It was very tough for me. Yeah.
Well, just like when how you mentioned the parents that didn't want to take your child back to the other clinic. Oh, I was just gonna say, how you were saying previous, you didn't really want to y'all didn't want to do the surgery for the little boy, because y'all were gonna send him back. Have you ever had a parent, another parent, where you just couldn't do it, even though they still wanted you to do it? Was there a child that you had to refuse because you just didn't think that you were qualified to do that operation?
Yes, we have some of the cases like that too. When you feel like, I don't have enough expertise of doing that, it's better you refer the patient that to hurt him.
But I understand it, but how those parents didn't want. You remember when you said you tried to send them back to the pediatrician?
Yeah.
With the new information. Do they still? I know you were the person. Evidently, God was the one that wanted you to do that. But it has been difficult at times to send them back again. Have you ever had just a difficult case, more extremely difficult than that one?
Yes, I do have a lot of cases like that. But if I feel like I can do it, it's better you do it than referring the patient back. But referring the patient back is really a problem. Some of the patients, in Malawi, people are very, very poor. You don't even know what they do to come in the hospital. Maybe they spend a lot of money to just come in the hospital. Maybe this is it. This is all they have. But when you have to refer to another hospital, then for them it's just impossible. Sometimes they just go home. So we're trying to balance all that. Do I really need to send them home? Then it's just better for me to help. So this is it. So we usually help. We try to help than sending them back.
But you must have transferred a lot to other places because you only have 200 beds and they come from other districts and you said other countries for treatment.
To send in other countries?
No, you said your hospital is 200 beds,
Yes.
right? And you serve that area, surrounding districts, and people from other country will come there. Don't you send away a lot, refer them to other places?
You know, in Malawi, you have to understand something. There is a free care. There is a free care for all Malawians in the government hospitals.
Oh.
But in government hospitals, now it is overcrowded. They are overwhelmed. Even though you send a patient there, for this patient to be seen, they can give him a rendezvous maybe 3 months, 6 months. You know, nobody will see. They say, okay, you come see the doctor after 6 months. And then even when you see the patient, for the surgery to happen, they give you another month. So what we treat in our hospital is actually the overflow from the government hospital.
Okay.
Those people who goes there, but they don't get helped, they come to us.
Okay.
Yeah.
You're doing an awesome job, though.
Thank you.
And you emphasize that you are the rural, these are mostly rural clinics that you're speaking of. Is that correct?
Yes.
And how do you recruit or find your students? Where do they typically come from, and how long do they have to train before they can feel like you can turn something over to them?
Yes. Actually, the hospital where I'm working right now in Malawi does not train surgeons yet. We get those surgeons from other programs. We have a wonderful program that is doing this. It's called Pan-African Academy of Christian Surgeons. They're actually training general surgeons, and they are, supplying those general surgeons through through mission hospitals across Africa. This is wonderful. Yes, but for the nurses, our own hospital has a school where we train nurses for our hospital. This is how it works. So, in our hospital, we also receive students just for their clinical rotation. We are not training them to stay with us, but some other students are coming from various institutions around, and they spend time with us, and they go back to their institutions. But training is really happening, but we just need to sustain that for long. That's why we need faculty. Yes. Yes.
So you had mentioned that you need faculty to come in and help train African faculty. The faculty from other countries, how can they best show respect for local traditions and customs when they come in and train African faculty?
Come again?
So the faculty coming from other countries,
Yes.
how can they demonstrate respect? How can they best demonstrate respect for traditions or how things are done at the hospital?
Okay. I'm not sure if I understand your question very well. But here we're talking about mission hospitals. We are Christians. So it's much easier with Christians than in a secular, environment, because Christ unites us very well, and in Christ this unity is really perfect. So even though those faculty are coming from overseas, they have Christ in them. They come in Africa, they find us, local faculties, but we work in a perfect relationship, they integrate very well, and that's why you can see some of the training happening, especially with Pan-African Academy of Christian Surgeons. You cannot believe. It's a perfect unity. So we think it's a matter of just being engaged. When they come in Africa, I don't think, I've never encountered a major issue, relationship-wise, between the faculty that are coming from overseas and those who are in Africa. Yeah.